Hi, so we'll discuss COPD today, chronic obstructive pulmonary disease or chronic obstructive airways disease. The definition of airway obstruction is an FEV1 to FVC ratio of less than 0.7. FEV1 FVC ratio of 0.7 to 0.8 is normal. Besides this, the other important thing about COPD definition is that it is a disease that is progressive. It progresses even despite discontinuing smoking. And in our part of the world, and in others like ours, where biomass fuel is used for cooking or heating, indoor heating or cooking in which there is biomass fuel and therefore that smoke exposure, cow dung, you've heard of chulhas being used. That's the most important cause of COPD in our female population, right? Of course, there are a lot of female smokers as well, but that's an important cause. So despite stopping such exposure that initiated or triggered the development of COPD, even after stopping such exposure, the disease progresses, which is why it is called airway obstruction that is progressive and that is not fully reversible, right? A little more about that in a while. Now, why is there airway obstruction? So, obstructive diseases are diseases of the airways, whereas restrictive diseases are diseases of the parenchyma, right? Or if not the parenchyma, the chest wall. What is the restriction? Obstruction is simple to understand. Obstruction to airflow. Restriction on lung volume, right? So, having discussed that basic difference, let's look at why there is airway obstruction in COPD, right? You've seen this previously, you've heard of this, you've probably read about this. So, this is the flow volume loop. Notice that flow is recorded along the y-axis. The part of the y-axis above the x-axis records the expiratory part of the maneuver. The part of the y-axis below the x-axis records the inspiratory part of the maneuver. I'll explain in greater detail. The x-axis records volume, and that flow rates increase both up and down. As you go away from the x-axis, flow rates increase. So, this here is the peak expiratory flow rate, and this here is the peak inspiratory flow rate. There is one important difference from most graphs. In most graphs, as you go from left to right along the x-axis, values increase. But here, please notice that as you go from right to left, come back towards the y-axis, volume increases. So, this here is residual volume and this here is total lung capacity. What happens to this loop in obstructive disease? So, obstructive disease, because the airways are narrowed now, they will shut off earlier than normal airways. So, if that's the normal loop, the airways are going to now shut off earlier, and therefore there is going to be the phenomenon called air trapping. When air gets trapped and you can't empty out the lung as fully as you would if you were not breathing in residuum of 900-degree incinerated leaves, then residual volume will increase. Air is trapped because we can't expire fully, exhale fully, and the residual volume increases. Now, is there an inspiratory problem? I've been harping on repeatedly expiratory problem. Is there an inspiratory problem? Will lung compliance change for the patient with COPD, with hyperinflated lungs? What happens, is compliance a static or a dynamic measure? Does it change with lung volume is what I'm asking. Lung compliance is unit change in lung volume per unit change in airway pressure. So, when you compare partially deflated or partially inflated alveoli with fully inflated alveoli, what's the difference in the surfactant concentration available per unit surface area in both these conditions, right? If there is 1 unit of surfactant available in the partially deflated alveolus, that concentration is obviously lesser in the fully inflated alveolus. What that means is that with inflation, as you inflate the lung, as lung volume increases, compliance will decrease, elastic recoil will increase. Lung compliance decreases with inflation and elastic recoil increases with inflation. The opposite happens with exhalation, with reducing lung volume, right? So, because of this air trapping, a lot of air trapped in the alveoli, the lung compliance is lesser. The unit change in these patients per unit change in airway pressure will be lower. So, they have to work very hard even during inspiration. Okay, you've heard of pulsus paradoxus, right? What is a pulsus paradoxus? Go on. Is it an inspiratory phenomenon or an expiratory phenomenon? Exaggerated fall of more than 10 millimeter mercury in systolic blood pressure during inspiration, right? So, two things. One, a fall of up to 10 is normal. Two, it is an inspiratory fall. Now, we've been saying COPD is predominantly an expiratory problem. So what's the problem with inspiration? This is the problem with inspiration. They have to generate so much intrathoracic, negative intrathoracic pressure to be able to take even a tidal breath that the systolic blood pressure falls by more than 10 millimeter mercury during that inspiratory effort. So much work of breathing is increased. So when that work of breathing is increased, they can't generate so much maximal inspiratory flow. Their maximal inspiratory flow rates are reduced. We saw that residual volume is increased. A lot of the lung parenchyma is destroyed. Okay, so what happens is that, and there is a lot of air trapping in the lung. So total lung capacity either remains the same or slightly increases in the COPD patient, right? And peak expiratory flow rates. Now the airway wall will start to shut off very quickly. So peak expiratory flow rates are blunted. If peak expiratory flow rates are blunted, the airway walls will start to shut off very quickly. Then what's going to happen is that during the latter half of that downstroke, lung will empty very slowly, right? So this therefore is called the scooped out appearance of the flow volume loop, right? What happens to the loop quickly in restrictive disease is that there is more of a problem with inspiration, right? There is a restriction on lung volume. The airways are normal, so I can expire perfectly normally, right? In fact, the FeV1 FVC ratio is higher than normal in restrictive disease. Ratio of less than 0.7 is the definition of airway obstruction, whether you're talking of COPD, whether you're talking of asthma, whether you're talking of bronchiectasis, bronchiolitis, anything. Like fever is an AM temperature of more than 98.9 or a PM temperature of more than 99.9, no matter whether it's because of typhoid, TB, malaria, HIV, whatever. Similarly, airway obstruction, no matter the cause, the definition is an FeV1 to FVC ratio of less than 0.7. Normal ratio is 0.75 to 0.8, and a higher than normal ratio of FeV1 to FVC is seen in restrictive disease. They can empty the lung out very fast, right? Because of the increase in elastic recoil. their pulmonary parenchyma is more fibrosed, or their chest wall is more stiff. So they empty out the lungs very fast. But they have a problem inspiring to maximal lung volume, right? So if there is a lot of fibrous tissue or the chest wall is very stiff, then what primarily happens is that TLC gets affected. The residual volume more or less remains the same. I said that expiratory flow rates do not change, but peak inspiratory flow rates are slightly reduced. The biggest problem there is the drop in TLC, right? So you will notice that vital capacity reduces in both types of disorder. In patients with obstructive disease, there is predominantly an increase in residual volume with a normal TLC. So therefore, the difference between the two, or vital capacity, reduces. In restrictive diseases, there is a decrease in TLC with more or less a normal residual volume. Again, the difference is reduced. The difference is vital capacity. Okay, we move on to the definition of COPD. So I told you that it is persistent, right? Persistent means it is not an episodic disease. This is how you distinguish it from the other very common airway obstructive disease, which is bronchial asthma, right? So the definition gives you, is objective and tells you how COPD is different from bronchial asthma. Asthma is an episodic disease. COPD patients have persistent symptoms. In easy everyday language, they are never symptom free. They will have cough and sputum production and breathlessness almost every day, right? There will be periods when they'll get an infection and then they'll be worse off, their blood gas will be poorer than earlier, but no symptom free intervals. Whereas bronchial asthma, you treat them well, they are as fit as a fiddle, you can't hear their chest is as clear as a whistle, you can't hear any wheeze, rhonchi, they're perfectly alright. So it is an episodic disease. So COPD is also progressive. I told you what progressive means. Despite stopping the exposure that caused the disease to initiate or trigger off, it still worsens over time. With as years go by, their FEV1, you measure their progression by the FEV1. A little more about that in a minute. It's not fully reversible. Full reversibility is an increase in FEV1 of more than equal to 12% by 2 puffs of a short-acting beta agonist. This is the definition of full airway obstruction reversibility, and you see this with asthma, right? So the definition is airway obstruction, which means an FEV1 to FVC ratio of less than 0.7, persistent symptoms, disease that is progressive and not fully reversible. I told you that this is how you distinguish between these two entities, daily versus intermittent symptoms, partial versus full reversibility, and the disease is progressive, whereas it is episodic and non-progressive for asthmatics. So COPD is 3 different entities which coexist in the same person. So you will see all these entities in the same patient, right? They might differ in extent, they might differ in distribution, but you will see all 3 together. I'll tell you what each of these is. Chronic bronchitis is chronic cough and sputum production. Actually, this was the old definition of COPD. The old definition of COPD was cough and sputum production for at least 3 consecutive months for 2 consecutive years. Now, this is a clinical definition and it's been done away with. 1, it's not objective. 2, a lot of smokers will develop such cough and sputum production many years before they have any airway obstruction. Understood? So, cough and sputum production cannot be taken as the surrogate marker of an obstructed or narrowed airway. So, this definition is done away with, right? That's one. So, chronic bronchitis, if you're still asked or you want to know what chronic bronchitis implies, it implies a chronic cough and sputum production. Another important thing, they asked a question on this in one of the recent INI-CETs is the Reed index. So, a ratio of thickness of the mucus gland layer to the total thickness of the airway wall, if this is more than 0.44, that means your patient has chronic bronchitis. Okay, side issue. Emphysema is an anatomical or a radiological diagnosis. It's not a clinical diagnosis. Even though these patients are called pink puffers, that is, they maintain near normal oxygenation, they don't get cyanosed as fast as the chronic bronchitis patients at the cost of increasing their work of breathing. Puffer, they hyperventilate and somehow maintain a normal PO2. So, emphysema, going back to what I was saying, is an anatomical or radiological description term. So, it means in emphysema, you get enlargement of air spaces. What that means is that the alveolar walls, if this is the alveolar units in someone who's both a non-smoker and does not stay in Delhi, and this is therefore then the same unit in someone who has either a 20-year pack history or, like me, is unfortunate to have lived in Delhi for most of his life, then you will notice that this airspace is enlarged because of destruction of the alveolar walls. The alveolar walls get destroyed. This causes an enlargement of the air spaces, right? This is emphysema. You can see this radiologically when there are a lot of such spaces and you see hyperinflated, focally hyperinflated. I'll just show you what that CT image looks like. Focally hyperinflated areas in the lungs, right? So, it is an anatomic or radiologic descriptive term. Small airways disease is what really defines COPD. So, small airways are airways that are less than 2 millimeter in diameter. MCQ for you. Another MCQ, this is the site of maximum airway resistance in COPD. Another MCQ, what is the site of maximum airway resistance in a healthy individual? Is it the small airways, the medium-sized airways, the main stem bronchi? None of those. The site of maximum airway resistance in health is the trachea. Why? Trachea is huge, right? Trachea is wide, but for all the air that passes through it, it is the narrowest part of the airways. All 500 ml of a tidal breath must pass through the trachea. Then it gets distributed first into both lungs, then into all the small airways, right? So, for the amount of air, the volume of air that is passing through it, the trachea is the narrowest part of the airway. Okay? So, this is the site of maximum airway resistance in health. The site of maximum airway resistance in COPD is small airways, which is airways less than 2 millimeter in diameter. Another MCQ is what's the site of disease in bronchiectasis? Is the segmental and subsegmental airways or medium-sized airways. Now, another MCQ from there is what are the causes of large airway, proximal airway or central airway bronchiectasis? It's starting to sound like I'm doing a tangential thinking demonstration for you. ABPA, I'll go back to enough of those tangents. I'll go back to COPD. All these three you will see coexist together in the same patient. Cough and sputum is chronic bronchitis, alveolar destruction and consequent enlargement of the air spaces is emphysema, and small airways disease is when the airways less than 2 millimeter in diameter are affected. They are narrowed down and they are also destroyed and reduced in number. Okay, let's go to pathophysiology now. Fine. And you will notice that although I said that it is predominantly obstructive disease is predominantly an airway disease, there is also parenchymal destruction and parenchymal pathology in COPD. The defining feature is airway obstruction. Because of this airway obstruction, you get hyperinflated lungs, you get air trapping, you get an increase in residual volume. Because of this increase in residual volume, while it is predominantly an expiratory problem, they have to generate much higher intrathoracic negativity for even a tidal breath, and therefore with severe obstruction they manifest a pulsus paradoxus. And then of course, as the disease progresses and worsens, they start to develop chronic respiratory failure. So they develop chronic hypoxemia and chronic hypercapnia, right? So that's all the broadly the sum total of what happens in COPD. So that's the quick summary of what happens. Such exposure recruits inflammatory cells, proteases are released, there is death and destruction in the lung and disordered repair, which leads to the permanently damaged lung of COPD. In a little more detail, when this exposure is repeated, the cells release the proteinases, there is not only cell death but also loss of extracellular matrix. I'll just come to the elastase, anti-elastase hypothesis, right? You also know of why elastase and anti-elastase are important, because you've probably heard of a disease called alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin is one of the naturally occurring proteases, and when there is a deficiency of alpha-1 antitrypsin, there is an increased expression of neutrophil elastase, and that damages the lung even in non-smokers, right? So a lot of elastin is destroyed, and therefore the alveolar destruction leads to disordered repair. The air spaces are enlarged, so the alveolar spaces get enlarged, and the airways that are leading out of these enlarged air spaces are narrowed. Correct? So, enlarged air spaces, narrowed airways. Airspace and airway are not synonymous with each other. Airway is the conducting system that brings air in and takes air out of the lung. Airspace is where gas exchange takes place. So, it's the respiratory bronchioles and the alveoli. Okay. Besides this, another thing that damaging influence of smoke, cigarette smoke or BD smoke, is that it impairs phagocytosis, it impairs mucociliary activity. The mucociliary escalator function is lost. There will be more bacterial accumulation and infection in such airways where phagocytosis is impaired, where ciliary clearance is impaired. This bacterial infection will itself, those bacterial toxins will themselves cause more airway damage and produce mucus, which will further narrow the airway. Okay. Mammalian target, you might get questions on this. So the mammalian target of rapamycin is protein kinase that is constitutively expressed in almost all cells of the body, right? And it regulates cell survival, cell metabolism. Importantly, it inhibits autophagy of the cell. Smoking inhibits this protein kinase and therefore leads to increased cell death. You see that mTOR inhibits cell autophagy. Smoking causes inhibition of this protein kinase and therefore increase in cell death. Okay. Elastase, anti-elastase hypothesis. So there is supposed to be a balance between proteases and anti-proteases. Alpha-1 antitrypsin is a naturally occurring inhibitor of neutrophil elastase. So when it is deficient in the alpha-1 antitrypsin deficient patient, you will have emphysema even if the patient is a non-smoker. This is the same imbalance that occurs in smokers. In smokers, there is an increased lung expression of elastases and a decreased expression of anti-elastases. That imbalance will therefore favor degradation or breakdown of elastin and therefore cause disruption of the extracellular matrix. Now, why is this disruption of extracellular matrix important? Because as the scaffolding, what is scaffolding? You've seen buildings being constructed with, pipes or a structure outside, a superstructure outside based on which the building is built. That is scaffolding. So that basic scaffolding, that basic structure on which the alveoli, the pulmonary vessels, they interact with each other, the airway walls are distributed in the lungs. When this basic structure is destroyed, the repair that happens leads to formation of an abnormal lung, right? So remodeled lung is because of this disruption of extracellular matrix. NF kappa B, normally NF kappa B is not exposed in normal chromatin. Now this is why COPD is a progressive disease. Please pay attention. So what happens is that smoking, the oxidative damage, the oxidants that are produced tend to inactivate histone deacetylase, and the acetylated or loosely arranged chromatin causes the NF kappa B to get exposed. Matrix metalloproteinases and cytokines which are not normally produced in such high quantities in normal individuals start to get produced in very high quantities. Now this is a genetic change. So it's occurring at a very phenomenal basic level. So when these cells give rise to progeny, those cells, even when they are not exposed to such smoke or such damage, will continue to express NF kappa B, and that NF kappa will continue to increase transcription of these damaging enzymes. Okay. Another thing is superoxide dismutase 3. It is an antioxidant. It's reduced in COPD. Right. So there are some facts there that help you understand about COPD, why it is a progressive disease, why it is an obstructive disease, and there are some facts that are factual. Now, when the alveolar wall gets destroyed, a lot of these small pulmonary vessels are also lost. So again, total cross-sectional area of the pulmonary vascular bed also reduces. Pulmonary vascular resistance therefore increases. And the second is because of chronic hypoxia, they develop pulmonary vasoconstriction. This gives rise to pulmonary hypertension and eventually right heart failure. How can we try and change this natural history? Is by giving them supplemental oxygen. The only pharmacologic maneuver that improves the survival of COPD patients is long-term oxygen therapy, right? So more on that in a little while, right? So the pathologic changes in small airways, one is that there is a narrowing of these airways, and the narrowing is because of multiple things. It's because of smooth muscle hypertrophy, it's because of fibrosis and remodeling, right? Another important thing is that you get a goblet cell metaplasia in these small airways. I told you the small airways are the site of maximum airway resistance in COPD, right? Another thing is that resistance because of narrowing, and the narrowing itself is because of smooth muscle hypertrophy and fibrosis. Another thing is that there is a goblet cell metaplasia. These goblet cells replace club cells. Club cells normally produce surfactant. And two things about this. One is that the normal healthy individual has goblet cells only in the trachea and bronchi, whereas the COPD patient has goblet cells throughout the tracheobronchial tree. So that's a metaplasia, correct? And because these clubs so increase mucus, that also leads to more airway narrowing. Another problem is that since they are replacing the club cells, it causes surfactant deficiency, and that tends to cause alveolar collapse, right? I told you all of that. Is there a change in the large airways? In the large airways, you get an increase in mucus glands, you get goblet cell hyperplasia. These are all potential MCQs, right? So you don't get a goblet cell metaplasia in the large airways. Goblet cells are a normal component of the large airways. It's a metaplasia when you see those cells in the peripheral airways or the small airways, and you get a squamous cell metaplasia. Now, what's the consequence of squamous cell metaplasia in large airways? Two problems. One is the mucociliary function is lost, so clearance of secretion suffers. Second is that it predisposes to malignancy, right? Okay, so mucus gland enlargement, goblet cell hyperplasia and squamous metaplasia are part of the changes, pathologic changes in the large airways. In the parenchyma, we've discussed its emphysema, and that's because of alveolar and respiratory bronchiole destruction. There are broadly three types of emphysema, and the first there is centriacinar emphysema, and that typically affects smokers and usually largely affects the upper lobes and the superior segments of the lower lobes. And there is panacinar or panlobular emphysema, and panacinar or panlobular emphysema affects patients with alpha-1 antitrypsin deficiency. It's predominantly lower lobe in distribution. There is a third variety which is seen in some patients with panacinar emphysema. It's called paraseptal emphysema. Okay, so centrilobular, smokers, upper lobes. Panacinar, alpha-1 antitrypsin deficiency, lower lobes. Paraseptal is a part of the, is seen in some patients with panacinar emphysema. That's how it looks. You will see distinctly hyperinflated units. So this is centrilobular or centriacinar emphysema. This is panacinar or panlobular emphysema. You will see that the entire lung has similar radiolucency, whereas here there are pockets of increased radiolucency. So that's the difference between centrilobular and panacinar emphysema, right? Just quick sum up of what we said. Large airways, you get mucus gland enlargement, you get goblet cells hyperplasia, and you get a squamous metaplasia. The small airways are narrowed because of a smooth muscle hypertrophy. You get goblet cell metaplasia. These cells are not normally seen in the peripheral airways, and you see respiratory bronchiolitis. Parenchyma, there is a destruction of the gas exchanging air spaces. That's summing up everything that happens pathophysiologically or pathologically in COPD patients. Centrilobular quickly, smokers, upper lobes. Panacinar quickly, alpha-1 antitrypsin deficiency, lower lobes. We move on to risk factors. We discussed smoking, and we discussed a lot about that, how cigarette, bidi, hookah smoke that is inhaled into the lungs can cause COPD. We discussed cigar and pipe smoke because it's alkaline and does not need to be inhaled into the lung, will not cause COPD. Besides this, we discussed biomass fuel exposure, fuels that are used, biofuels that are used for indoor heating and indoor cooking can cause COPD. Air pollutants can cause COPD. They can worsen COPD. Then there is an entity called airway hyperresponsiveness, right? This is one of the factors that more commonly is responsible for bronchial asthma, right? But so It simply means the airway is excessively responsive to a number of stimuli that may be noxious or non-noxious. They may or may not produce the same manifestations in someone who does not have airway hyperresponsiveness. So, stimuli that are normal for or that are that do not trigger bronchospasm and inflammation in the airways will do this to people who have hyperresponsive airways. Now, you also know of the entity called ACOS, asthma COPD overlap syndrome, right? So, in these patients, what happens is usually is that there are two hypotheses. One is that you know that asthma is predominantly an eosinophilic inflammation, eosinophil driven inflammation. Asthma that is neutrophilic, driven by a neutrophilic response, is more likely to progress to ACOS. It is more likely to not respond to usual therapy for bronchial asthma. So, inhaled corticosteroids and bronchodilators do not produce as good an effect in neutrophil rich asthma as in eosinophil rich asthma. That's one. The second is, even the usual eosinophil driven asthmatics, if they are poorly managed and the airway inflammation persists unchecked, what is going to cause airway damage? So, they go on to develop a COPD phenotype. The lung starts to get permanently damaged and remodeled, very much like what happens in COPD, right? So, cigarette smoking, besides that, what are the other forms of smoking we've discussed? We discussed airway hyperresponsiveness. Infections of themselves will not cause or predispose to COPD, but someone who has a hyperresponsive airway, someone who has a heavy history of heavy smoking, will be more prone to develop COPD early if they have recurrent LRTIs, right? Occupational exposures can cause COPD, like bicyanosis. Sugarcane dust exposure can cause bicyanosis and can cause obstructive airways disease. Air pollution we discussed. Again, air pollution of itself will not give rise to chronic hypoxemic or chronic hypercapnic respiratory failure. It will not be, it is very unlikely that it will be a progressive disease, but it will worsen the tissue effects of cigarette smoke. Alpha-1 antitrypsin deficiency. Now, that's a very, very important risk factor for COPD. Now, alpha-1 antitrypsin is a protease inhibitor. So, it inhibits, in the lung, it inhibits neutrophil elastase and therefore does not allow it to degrade elastin or the extracellular matrix, the most important component of the extracellular matrix in the lung, right? The deficiency is an autosomal recessive disease with codominant expression. What does codominant mean? Codominant means that both the alleles contribute equally to the phenotype of the to the clinical phenotype. Codominant means that both the alleles contribute equally to the phenotype, the expression, the clinical expression. Very similar to blood groups, right? There are three alleles. The M allele is the normal allele. The S allele is associated with mild deficiency, and the Z allele or the Z allele is associated with severe deficiency. So, someone with both M alleles will have more than 90% of normal of the tissue levels of alpha-1 antitrypsin. Someone with both Z alleles or Z alleles will have less than 10% expression, tissue expression of AAT. Someone with PIMZ alleles, one M and one Z, will have expression somewhere between 10 and 90, and they would have much milder phenotype compared to someone with SZ, right? I hope you understand what codominance means. There is also something called a null allele, in which a null allele means these patients will not synthesize alpha-1 antitrypsin at all. Okay, so how does this manifest? One is that it causes pan-acinar emphysema, which we discussed is more prominent in the lower lobes of the lung. It can also predispose to bronchiectasis. It also predisposes to liver cirrhosis. See, why liver cirrhosis is because the abnormal alpha-1 antitrypsin protein. The problem is when it is mutated, the protein chain is abnormally folded. So an abnormally folded protein chain, it's synthesized in the liver. So an abnormally folded protein chain lies in the hepatocytes, and that is cleared away when that concentration is very high. The loss of the hepatocellular necrosis and loss as a result of the macrophage clearing of the abnormally folded protein results in chronic hepatocellular damage, inflammation, and ultimately fibrosis. Okay, so I told you autosomal recessive with codominant expression. Codominance is, we discussed that, we discussed the 3 alleles and the null allele. So ideally all patients with COPD should undergo testing for alpha-1 antitrypsin levels. Reason being that there is no reason why someone who's a smoker should also not have alpha-1 antitrypsin deficiency. In such a patient, when you identify such a patient and you give replacement therapy, so you can give weekly injections of alpha-1 antitrypsin, and that will obviously reduce further worsening, reduce the speed at which lung function deteriorates. And we discussed how all these features can be seen in patients with alpha-1 antitrypsin deficiency. That's the staging. GOLD is Global Initiative for Obstructive Lung Disease. The staging is based on the FEV1. That's what you should remember. It's extremely unlikely that they will ask you if someone has an FEV1 of 45%, what stage of COPD is it? No, that's not important. So it's important to understand that it's based on the FEV1. It's important to understand that the FEV1 is a measure of expiratory ability. The amount of air that can be exhaled in the first second of a forced expiratory breath is FEV1, right? So it's a measure of expiratory capacity, and that's in keeping with what we discussed. Obstructive diseases have more of an expiratory limitation than an inspiratory problem, right? Another thing that we discussed about FEV1 is how it is related to clinical expression. So more infections and chronic hypoxemia when it's down to 50, and chronic hypercapnia, pulmonary hypertension when it's down to 25. Remember that in all these patients, the FEV1 FVC ratio will remain less than 0.7, because that's the very definition of airway obstruction. We come to the pulmonary function test findings. Because of the airway obstruction, which implies poor expiratory capacity and the hyperinflation, these are the 2 phenomena that underlie all the pulmonary function test findings. So the airway obstruction tells you that the expiratory capacity is limited. Expiratory capacity is measured specifically by the FEV1 FVC ratio, and that's how it's defined. Staging is done by the FEV1, again an expiratory measurement. Because of air trapping, the functional residual capacity and the residual volume are increased. Because these are increased, these patients have increase in work of breathing. More on that later, right? And the hyperinflation leads to an increased total lung capacity. There is one more factor that allows an increase in TLC. One is, of course, the air trapping and the hyperinflation, consequent hyperinflation. The second is that if there is widespread emphysematous damage, alveolar septal damage. Now the alveolar septa are where the elastic recoil of the lung resides. That's the seat of elastic recoil. That's where elastic recoil is exerted from. So if all that tissue which is exerting elastic recoil is reduced, that recoil capacity is also reduced, and that allows the lung to be inflated to a chronically higher volume, right? And since the residual volume is high, very high, the TLC is either normal or only slightly increased. The residual volume to TLC ratio will be increased in patients with obstructive airways disease. It's also increased incidentally in patients with restrictive disease. In those patients, what happens is there is a big fall in TLC. The residual volume remains more or less normal, and that's the reason they have an increased residual volume to TLC ratio. So a decrease in vital capacity and an increase in residual volume to TLC ratio. These two findings are common in obstructive and restrictive diseases on the PFT. Right? Alright, let's keep moving. There are multiple mechanisms of hypoxemia. Right? What are the various reasons that someone can be hypoxemic? One important reason can be a reduction in the atmospheric PO2, which is what happens when we go to Ladakh, right? Which is what happens when someone is exposed to a raging fire, carbon monoxide poisoning, right? The fire consumes the oxygen, that will result in hypoxemia, right? Then any other cause, then there are causes in which there is a shunt physiology operating. Can you think of any common shunt physiologies in the lung, diseases of the lung, which cause hypoxemia? Very simple. What happens when a patient has a right lower lobe pneumonia? That entire lobe will not be aerated, but it will still be perfused. So all that output from the right heart goes back to the left heart without getting oxygenated, and that's the definition of shunt, right? So that's one mechanism of hypoxemia. Another mechanism of hypoxemia is a ventilation perfusion mismatch. So there are parts of the lung which are being ventilated well but not perfused well, and vice versa. There's parts of the lung which are being perfused well but not ventilated well. Now this is the kind of abnormality that's primarily responsible for hypoxemia in COPD. So because the pulmonary capillary destruction and the alveolar septal destruction are not uniform throughout the lung. In some places there will be more septal destruction, in other places there will be more capillary destruction. So there is a ventilation perfusion mismatch. Now what's important about this is that how would these two physiologies, these two conditions respond to supplemental oxygen? Which do you think will respond better? Shunt or ventilation perfusion mismatch? See, in a shunt, when you give supplemental oxygen, what are you basically improving? You are improving oxygen supply to the already well aerated and well perfused parts of the lung. If you took the example of right lower lobe pneumonia, so all the other lobes are being appropriately perfused and ventilated even before you were giving supplemental oxygen. And how is supplemental oxygen going to help here is that it's only going to increase the dissolved oxygen in blood. How much oxygen is carried in that manner? If 21 ml of oxygen is carried per deciliter of blood, 19.3 is carried attached to bound to hemoglobin, and only about 2 ml, less than 2 ml is dissolved in blood. That's the difference in the oxygen carrying capacity of blood in solution, oxygen in solution versus oxygen bound to hemoglobin, right? You won't get a big difference with shunt physiologies with supplemental oxygen. What's going to happen with ventilation perfusion mismatch? There's a part of the lung which is being well perfused but not well ventilated. Now, when you give supplemental oxygen, you raise the alveolar PO2 even to such alveoli, and suddenly the hemoglobin binds to more oxygen is available to bind to hemoglobin perfusing those alveoli. So this will respond beautifully. So this is one important clinical outcome of what the cause of mechanism of hypoxemia is, right? So ventilation perfusion mismatch is the predominant mechanism for hypoxemia in COPD. I told you why. Because of non-uniform destruction of a pulmonary capillary tree and alveolar units. Then this physiology, this kind of a pathophysiology responds very well. So you give them supplemental oxygen, and with 1 to 2 liter per minute of oxygen with a nasal cannula, which means 24 to 28% oxygen, their chronic hypoxemia goes away. Then they come back to a almost normal saturation and PO2. Okay. When a COPD patient does not respond to a low flow oxygen, the hypoxemia fails to respond, you have to look for a possible shunt physiology. Your patient might have a collapse, your patient might have something else also. Your patient might have a pneumothorax, right? So that's the importance of knowing what contributes to or what causes the hypoxemia in COPD patients, right? So we said when hypoxemia is difficult to correct with supplemental oxygen, you consider an additional or alternative explanation. This we've discussed the clinical correlation of FEV1 with the outcomes and expression, right? Now, so the first point here is that hyperinflation preserves FEV1. How? Is that as lung volume increases, elastic recoil also increases. We said that compliance or recoil is a dynamic measure of the expansibility of the lung. So it's not a static measure. So as lung volume increases, compliance reduces, or in other words, elastic recoil increases. What happens with elastic recoil is that if the recoil is increased, one way it helps is that it ensures that the lung empties relatively more easily. Correct? So, because recoil is what pushes air out of the lung. Okay? We discussed what is it that establishes the gradient for expiration. The normal gradient for expiration is the elastic recoil. And when that is increased, that will allow faster emptying of the lung, not compared to normal, but faster compared to if that same COPD patient had no change in elastic recoil, right? So that logic is a little fuzzy. Fine. We are not comparing it to the normal healthy individual. We are comparing it to that same patient if the elastic recoil remained unchanged. So that is one benefit of hyperinflation. One of the problems with hyperinflation is by this same virtue, work of breathing is increased because compliance is reduced. Elastic recoil is the ease with which lung can empty. Compliance is the converse of that, the ease with which you can inflate the lung to a certain volume. Correct? So, because that is the chronically reduced, they have to, their work of breathing increases. I explained how, on the basis of available surfactant per unit surface area. Okay. And that also takes us to, we've discussed this as well, an exaggerated fall of systolic BP of more than 10 during inspiration is a pulsus paradoxus. It is evidence of very severe airway obstruction, and very severe airway obstruction causes hyperinflation. Hyperinflation implies that the compliance is reduced. Poorly compliant lung How do you inflate it? You have to generate a very highly negative intrathoracic pressure for a tidal breath to come in. That highly negative intrathoracic pressure manifests as an exaggerated fall in systolic BP. Correct? Now, this also means that a fall of up to 8 is normal. Why is that? That's because of that is again the same thing. It's because of the negative intrathoracic pressure that is required for a tidal inspiration even in perfect health. Right? We said that that negative pressure is transmitted to all structures in the thorax, so that the dilatation of the great vessels of the aorta, for example, is responsible for that small fall in systolic BP, which is physiological during inspiration. Okay. So, switching now to how it clinically manifests, one important and interesting sign that you will see, we were discussing hyperinflation, is what is called Hoover's sign. This is the normal individual. You will see that the diaphragm contracts more in a craniocaudal manner, up and down. What happens when the lungs are chronically hyperinflated is that the domes of the diaphragm get pushed downward, and now the diaphragm starts to contract in a radial manner, right? So it contracts inward. So when the lower chest wall is drawn inward during inspiration, that is called Hoover's sign. Have you heard of the neurological Hoover's sign? The neurological Hoover's sign is seen in patients who are malingering a paraparesis. So, I'll quickly describe that. You keep both your palms beneath the heels of a patient who's complaining of a lower limb weakness. You ask them to try and raise one leg or one foot. If they are genuinely trying to raise one foot, you will feel a pressure on the contralateral hand. If you don't, that is a Hoover sign, and it is evidence of malingering, right? Okay, so going back to the respiratory Hoover sign, inspiratory indrawing of the lower rib cage is Hoover sign. It is evidence of flattening of the domes of the diaphragm. Normally, the chest wall would move outward with inspiration, right? So, clinical features very quickly, cough, dyspnea and sputum production is what you will get on the history, right? And besides that, on general physical exam, you will see that these patients have a polycythemia, a spurious polycythemia or a secondary polycythemia because of two things. One is that cigarette smoking is the commonest cause of chronic carbon monoxide poisoning, and that causes hypoxia, tissue hypoxia that pushes up erythropoietin levels secondarily and therefore leads to polycythemia. Another is of course the chronic hypoxemia that develops when their FEV1 falls to 50% or less, right? So that's one thing that you will see. Another thing that you will see is that they will be initially on when they walk in or they're sitting in the ER, you will see very prominent accessory muscle use, right? Their sternocleidomastoids may even be hypertrophied from the daily overuse, because remember, they have persistent symptoms. They are symptomatic every day. When their FEV1 falls, it is very unlikely that it will come back to normal after that episode or exacerbation is over. Okay. So, another thing that you will see is a barrel chest. Normally, the anteroposterior diameter, anteroposterior diameter to transverse diameter, the ratio is 5:7. The transverse diameter is more than the anteroposterior diameter. When the anteroposterior diameter starts to increase and approximate the same, the transverse diameter becomes almost as much. What is a barrel? A barrel is like this, right? There is no difference between its various diameters. So that's what happens in COPD, is that their anteroposterior diameter starts to increase. Okay, that's a barrel chest, and you will notice that the anteroposterior and transverse diameters have started to become similar to each other. Okay, why is this happening? The barrel chest, it's an expression of the normal elastic recoil of the chest wall. Now it's getting freed from the inward recoil. The normal elastic recoil of the chest wall is outward, correct? The normal elastic recoil of the pulmonary parenchyma is inward. So when this recoil is reduced because of pulmonary parenchymal destruction, the chest wall is free to spring more outward. Okay, that's barrel chesting. Besides that, we discussed about accessory muscles, the sternocleidomastoids, tripoding. So they need to, because they are using accessory muscles, what they do is they would sit like this, or they would sometimes sit with their arms behind their trunk. So they try to fix their trunk, their upper limbs and their neck, so that the accessory muscles can contract more effectively. This position is called tripoding. So they would sit with their arms fixed either in front or behind the trunk. If they are sitting on the ER bed, you will see them often leaning back. That's also tripoding. They're just basically fixing their back, their upper limbs and their neck, so that the accessory muscles can contract more effectively. Okay. So cyanosis, usually it is an evidence of advanced disease. We discussed that hypoxemia sets in when their FEV1 is 50 or less. Similarly, we also discussed that these patients have right heart failure, and evidence of that, peripheral edema, raised JVP, is evidence of right heart failure. Besides this, tender hepatomegaly is also evidence of right heart failure. And these are of course seen when the patient's FEV1 has fallen to 25% or less of the normal value. One important feature here is cachexia. Malnutrition is a very, very important aspect of COPD. Why? Because it is an independent predictor of mortality in these patients. And it's because of the catabolic state, which is in turn is because of the chronic inflammation, chronically ongoing inflammation in the lungs. Okay. On palpation, you'll find features of pulmonary hypertension. So you'll find a palpable P2 in the pulmonary space. You'll be able to feel a left parasternal heave because of right ventricular overload. Right. A left parasternal heave and a palpable P2 on palpation. On percussion, there are two important findings. One is that tidal percussion will demonstrate that the excursion of the diaphragm should normally be moving craniocaudally. But because of hyperinflation, when the domes are more flat, it contracts radially. So what is tidal percussion? You go down, you go percussing downward, and when you experience the hepatic dullness, you ask the patient to take a deep breath. And the patient takes a deep breath, the diaphragm should move downward, and what was the note that was initially dull should now become more resonant. This distance across which you will feel this happening, you will be able to ascertain the craniocaudal excursion of the diaphragm. How much does it move will be reduced in COPD patients. Okay. Another thing that you will see is that superficial cardiac dullness would be reduced because of hyperinflation. On auscultation, what you will hear is prolonged expiration. It's more of a expiratory abnormality, obstructive airways disease. So the expiratory phase, the lung empties very slowly during expiration. So you will hear prolonged expiration. Small note there, if you want to assess expiratory time objectively, the place to do that is the trachea. You keep the diaphragm of the stethoscope on the trachea, and that's how you establish prolonged expiration, not on the lung fields. You will hear wheezes or rhonchi that are predominantly expiratory. With severe obstruction, they also become, you will also hear them in the inspiratory phase. You will hear scattered coarse crepitations in the lung because of multiple factors, because of secretions, because of repeated alveolar collapse and reinflation. You will hear scattered coarse crepitations. We go on to discuss the X-ray first, and what you see there, this is the typical X-ray of uncomplicated COPD. Now what you see there is hyperinflation, right? What are the objective evidences that suggest that there is hyperinflation? The first thing that is immediately obvious without looking at any further detail is the increase in radiolucency, right? The vascular markings are less prominent, and that implies an increase in radiolucency. Besides this, you will see that the intercostal spaces, when you go into more detail, are wider. Two ribs are more wide apart than in the normal X-ray. Another thing about intercostal spaces is that you can count more than 7 of them on an erect PA view of the chest if the lung fields are hyperinflated. The fourth thing that tells you there is hyperinflation is the flattened domes of the diaphragm, right? I'll just show you a normal chest X-ray and it will be easier to understand when you compare it with this X-ray to understand these findings, right? And the fifth manifestation because of hyperinflation is what they call a tubular heart. The mediastinum also gets compressed because of the hyperinflation. Now look at, in contrast, look at the normal healthy adults PA view chest. You will see that it is less radiolucent. The vascular markings are visible quite well right up to about 2/3 of the lung fields, right? In this X-ray, you can't see vascular marking almost at all beyond the hilum in the upper lobes, and the lower lobes, it's about half of the lung fields, right? Besides that, the intercostal space, look at the space between any two adjacent ribs, while look at the spaces here. You will notice that they are further wide apart. The intercostal space count of more than 7, it would be difficult to do that for you here, but 1, 2, 3, 4, 5, 6, 7 and 8. Whereas in the normal adult, 1, 2, you don't count these spaces. This is not the space that you should be counting, right? The space that you have to count is this one, the one that's visible behind. These are the spaces that you have to count. These spaces, right? So when you count more than 7 intercostal spaces on an upright PA view, it is evidence of hyperinflation. Then the domes of the diaphragm, the right dome is higher than the left, and the heart shadow, which is narrower, and they're referred to as a tubular heart in the COPD patient, right? Okay. When you look at a CT, a CT is useful for patients with emphysema. Uncomplicated COPD is what we're discussing, and you will see large bullae, large cystic spaces in which there are very few or no lung markings. These are emphysematous bullae, which are liable to, they are notorious to rupture and give rise to pneumothorax. So the CT helps you helps to tell you what is the extent of emphysema, what is the distribution of emphysema, is it predominantly upper lobe, is it predominantly lower lobe, is there a segment of the lung. There is, when we go to treatment, you will discuss about lung volume reduction surgery, right? And that's it's very uncommonly practiced, but it's a very useful method to improve survival in the COPD. It is only 3 methods which improve survival in COPD, right? So a CT assessment is essential to tell us which patients are appropriate candidates for such a procedure. What are the complications of COPD, right? These patients, because of when we discussed pathology, we said that they have a squamous metaplasia in the upper or large airways, and there are 2 important consequences of that. One is that their mucociliary escalator function, the clearance of secretions, normal secretions that you and I cough up daily, is affected, is reduced significantly in these patients. Cigarette smoke inhibits, of course, squamous metaplasia, of course, can give rise to malignancy. So when we are talking of complications, that's one complication. The loss of mucociliary escalator function and these cigarette smoke impacting phagocytic activity of macrophages, phagocytic activity impairment. These together will give rise to the predisposition to infection, right? So they can have exacerbations, the most common cause of which is an infection. Even a viral upper respiratory infection will cause a mild exacerbation of COPD, right? And the problem, why are we worried so much about an exacerbation? It is just, after all, a little worsening of what is already always there. These patients are always symptomatic, they have daily symptoms. What's so great about an exacerbation? Why are we so worried? We are so worried because with an exacerbation, mortality can approach 50%, depending upon how severe the exacerbation is, depending upon whether the patient needs hospitalization, whether the patient needs ICU admission, whether the patient needs intubation and ventilator support. Okay, so that's why with treatment of COPD, we are specifically going to focus on treatment of exacerbation and how to prevent one, right? Another complication that I just mentioned while I was showing you the CT was pneumothorax, and that's common because these patients have emphysematous bullae, right? And when there is a subpleurally located bulla, the pressure changes that occur in the thorax, even with simple cough, can give rise to a pneumothorax. Now, we've discussed with pneumothorax that you can classify them as spontaneous pneumothoraces, or which are non-traumatic, or traumatic pneumothoraces, and you can classify them as primary or secondary, depending upon whether the underlying lung is healthy or diseased. So these patients typically develop secondary spontaneous pneumothoraces. They are perfectly fine one moment, they have a violent bout of cough, and they develop sudden pain on the affected side, and they will develop severe hypoxemia, they'll go into respiratory distress, they'll be rushed to the ER, and of course the findings of a pneumothorax, right? Hyperinflated hemithorax on the affected side, tracheomediastinal shift to the opposite side, absent breath sounds, and a hyper-resonant percussion note, right? Besides this, pulmonary hypertension, cor pulmonale, right heart failure. Now, these are phenomena that develop gradually over a period of years or decades, right? Now, why have I mentioned that as one of the causes of an exacerbation? See, there is something called Bernheim effect. The Bernheim effect implies that a compromised left ventricle, that is a failing left ventricle, dilates, and therefore the IV septum bulges into the right ventricular cavity and compromises right ventricular function as well, right? And there is something called a reverse Bernheim effect. In a reverse Bernheim effect, a dilated right ventricle bulges the IV, causes the IV septum to bulge into the left ventricle and compromise left ventricular function. So, developing a biventricular congestive heart failure, developing in the COPD patient can cause an acute worsening of blood gases, of sensorium, of blood pressure, can even land the patient in cardiogenic shock, right? Besides this, coronary artery disease is one of the commonest causes of mortality in COPD. It is an indicator of the widespread inflammation in the body, right? So, there is a catabolic state, there is a widespread inflammation. These patients are therefore prone to atherosclerotic coronary artery disease, even if they have stopped smoking, right? That's another problem. Another complication of COPD that we discussed some time back is the development of a malignancy. What all can alert you to the development of a malignancy in a COPD patient? One thing that I mentioned some time back was digital clubbing. Is there anything else that can alert you to the to this ominous complication? So, if they've developed a neurological syndrome, right, which could be either due to metastasis or paraneoplastic. So, if they suddenly develop a peripheral neuropathy, if they suddenly develop an alteration of sensorium, but the blood gases are well maintained, there is no recent change in the respiratory function, the cardiopulmonary function is the same as it was at baseline, but they've suddenly developed an acute worsening of sensorium, they've developed recent ataxia. These are all manifestations of a paraneoplastic syndrome. Of course, hypercalcemia is another paraneoplastic syndrome that can develop in lung cancers, and these patients can have different manifestations, again one of which is an alteration of sensorium. Metastasis to different parts, the ones that are very quickly noticeable are metastasis to the vertebral column, because they can cause a compressive myelopathy, and therefore the patient will come with weakness and sphincter involvement, weakness in the lower limbs and a sphincter involvement. Metastasis to the intracranial space can cause seizures, can cause a sudden recent change, alteration in behavior, alteration in personality, and depending upon where the metastasis has lodged and how big it is, it can cause all those features. So, now we go to treatment, and as I have already described, treatment is divided into whether you're looking after a stable patient or you're dealing with an acute exacerbation. The exacerbations are important because of the implied high mortality rate, besides also being a load on the patient's resources and the country's healthcare resources. For stable COPD now, let's discuss that first. There are only 3 measures that improve survival. I have said that earlier. SOS is smoking cessation. You have to urge them to quit smoking, help them to quit smoking. Oxygen supplementation, the only pharmacological measure that improves survival in the COPD patient. The second S there is surgery, lung volume reduction surgery. Let's quickly look at all three of them. So how will you help them to quit smoking? You need to give them nicotine replacement therapy. You might need to give them a partial agonist at the nicotinic receptors, and that drug is called varenicline. What does a partial agonist do? A partial agonist is also called an inverse agonist, right? What that means is it will bind to the nicotinic receptor. If that's the nicotinic receptor, varenicline will bind to this receptor and produce submaximal stimulatory effects. So that even if this person smokes, that nicotine which he gets from his cigarette or his BD or his hookah will not be able to bind to this nicotinic receptor. And varenicline, because varenicline is occupying that receptor and therefore and producing a lesser effect than nicotine itself. Oxygen supplementation, long-term oxygen therapy or domiciliary oxygen therapy. I've said that already. When do you use it? If they have a resting PO2 of less than 55 millimeters of mercury, right? If they have a resting saturation of less than 88%, and if they have a resting saturation of less than 89% with pulmonary hypertension. Notice that this looks very small, 88% without pulmonary hypertension, 89% with pulmonary hypertension. But that's why is there that distinction is because of the sigmoid shape of the oxyhemoglobin dissociation curve. Below a saturation of 90%, if that's 90% hemoglobin saturation, below that there is very sharp fall in oxygen carrying capacity, the oxygen content of blood with each single percent drop in saturation, right? So, because oxygen will improve the hypoxia, as it improves alveolar hypoxia, pulmonary vasoconstriction and pulmonary hypertension will improve, and therefore right heart function will improve, right? So, I said that it improves, it reduces pulmonary hypertension and it improves right heart function. It will improve exercise capacity. Remember that for it to be useful, it must be given at least 14 hours a day. Mortality benefit is directly proportional to the number of hours that a patient uses oxygen. As little as 1 to 2 liters per minute administered with a non-interfering nasal cannula, the patient can do pretty much anything else while that oxygen is being administered, will ensure that the patient gets all these benefits of oxygen therapy, long-term oxygen therapy, right? Okay. The lung patients, we come to now the third measure that reduces mortality, improves survival in COPD patients. So these patients, I said that doing a CT will help you select these patients. So patients with predominantly upper lobe emphysema, is a large bulla that's affecting the right upper lobe, and that bulla is under so much tension that it is compromising the function of the right, middle and lower lobes as well. Or the same thing on the left side. Then you do a resection of that particular lobe, right? Or that bulla. So a partial pneumonectomy will help these patients, but you don't do it if patients have an FEV1 of less than 20%, a poor diffusing capacity, a DLCO of less than 20%, or it's not, localized emphysema. Diffuse emphysema, which affects almost all lobes equally, lung volume reduction surgery won't be helpful, right? Okay. Go to bronchodilator therapy. One of the important pathophysiologies in these patients is airway narrowing. There's a lot of airway narrowing which is because of fibrosis or remodeling, There's a lot of airway narrowing, which is because of inflammatory cell accumulation, and there's a lot of airway narrowing which is because of mucus hypersecretion, right? So there are some factors there that can be controlled with therapy and some factors that cannot be controlled with therapy, and this is why patients with COPD have only partially reversible airway obstruction. That's one criteria that's for the definition of COPD, correct? It's how you distinguish it from asthma, because asthma patients have either no fibrosis or remodeling or very minimal remodeling of the airways. Their airway obstruction is much more fully reversible than the COPD patient. You cannot obviously reverse a change that has occurred anatomically, which has changed the structure of the airways forever, right? So you can use short-acting and long-acting drugs as bronchodilators. Long-acting drugs are administered on a regular daily basis, whereas short-acting drugs are administered as and when needed. So, if the patient on a long-acting muscarinic antagonist develops dyspnea in the middle of the day, then they are asked to take a short-acting inhaler for that particular episode. Even when they are having an exacerbation, we give them short-acting medication, short-acting inhaled bronchodilators, either a beta agonist or a muscarinic antagonist for the duration of the exacerbation. So, long-acting agents administered regularly on a daily basis, short-acting agents administered as needed for an exacerbation or breakthrough symptoms even in the absence of an exacerbation. So, they can be anticholinergics, and these are short-acting muscarinic antagonists or long-acting muscarinic antagonists. Compared to the asthmatic patient, anticholinergic or muscarinic antagonist agents are much more useful in these patients. So, the asthmatic beta agonists are more useful bronchodilators. COPD patient, anticholinergics are more useful. The reason that anticholinergics are more useful in COPD while beta agonists are less useful comparatively is because when airways get destroyed, those beta 2 receptors are lost forever. So, when you give beta 2 agonist, it won't have locus of action as much as it would have in an undamaged airway. Right. So, short acting agent is ipratropium, which we often use in the emergency. It's also used in asthma exacerbations. Long acting agents are aclidinium, umeclidinium, tiotropium, and glycopyrrolate. I already told you why long acting muscarinic antagonists are more useful in the COPD patient. Beta agonists, so albuterol or salbutamol, they're just different names for the same medication, are inhaled agents. Tebutalin, I put that in parentheses or brackets because it's not available an inhaled formulation. So, it can be given orally, and in some countries it's also used parenterally or intravenously, right? And then the long acting ones are arformoterol, formoterol, indacaterol, olodaterol, salmeterol, and vilanderol. Okay, so these are drugs that are more useful for the asthmatic. Now, are there any other bronchodilator medications? So there is theophylline and its analogs like doxycycline, and they improve airflow, they improve vital capacity. The downside is that they have more adverse effects, and which are mostly cardiac or neurological. So you will see that these patients might have nausea, tremor, tachycardia. At higher doses, they might develop confusion, sometimes even seizures. So it's not a first line therapy. It is always only used as an add-on therapy. Another important thing is that when we are still discussing treatment of stable COPD. We are specifically looking for agents and measures that will reduce further exacerbations, and that is not one of the attributes of this class of drugs, right? Corticosteroids, see what happens is when the FEV1 goes to less than 50%, that's when they develop two things. They develop a chronic hypoxemia and they start to have recurrent exacerbations. So these patients, stages 3 and 4 on the Gould staging of COPD, are candidates for inhaled corticosteroids because they will reduce exacerbations of COPD, right? So we give them to those with frequent exacerbations, and a frequent exacerbation of COPD for any purpose. What is the definition of frequent exacerbations? If it's 2 or more per year, that is the definition that satisfies frequent exacerbation of COPD, right? So one in January, the other in December is frequent exacerbation, even if it did not require hospitalization. Even a single hospitalization is a poor risk marker for a COPD patient. I'll just come to that. Oral corticosteroids, on the other hand, should be avoided in COPD. They have an unfavorable risk-benefit profile. You do use them in the COPD patient, but only in hospitalized patients with an exacerbation. Okay. Another phosphodiesterase inhibitor, the other one that we discussed was theophylline. Another phosphodiesterase inhibitor is roflumilast, and again it reduces the frequency of exacerbations. It is to be given when the patient's FEV1 is less than 50%, right? So antibiotics, very important. Infection is the commonest cause of an exacerbation. So for an exacerbation, you will give empirical antibiotic therapy. You will give treatment that at least provides cover for Haemophilus influenzae, Streptococcus pneumoniae, and Staph aureus, provided there are no additional risk factors for a pneumococcal or a gram-negative pneumonia, right? And that we've discussed what those risk factors are, we discussed with respiratory infection. So you use antibiotics for an exacerbation, you start them on empirical antibiotic, and then based on, if you are able to identify a single organism based on cultures, then you step down to appropriate antibiotic as per this sensitivity pattern. You can also use antibiotics for preventing exacerbation. That class of drugs is macrolides. You can give them for a period of continuously daily for 6 months, especially useful in ex-smokers, right? This also reduces the frequency of exacerbation, right? Alpha-1 antitrypsin deficiency, for those patients who are deficient, you will give them weekly injections of alpha-1 antitrypsin replacement, and it's given for patients whose alpha-1 antitrypsin levels are less than 50 milligram per deciliter. Not every patient with alpha-1 antitrypsin deficiency will develop COPD. So those with a levels less than 50 milligram percent are candidates for replacement IV injections given once a week, right? Pulmonary rehabilitation. Now this sounds like a very sidey issue, right? Why? We are worried about respiratory failure, we are worried about hypercapnia, severe acidosis, respiratory muscle fatigue, the need for mechanical ventilation. Pulmonary rehab in the scheme of things seems like a very small thing to worry about. But what did I say about nutrition is that malnutrition in the COPD patient is an independent predictor of mortality. So you have to, that's why we had discussed tricep skin fold thickness assessment, scapular skin fold thickness assessment, asking them to do some aerobic and weight training exercises to improve muscle performance and muscle bulk, right? So exercise and nutrition, the aim is primarily to preserve muscle strength. You're not asking them to participate in their local Mr. Delhi contest or Mr. Bombay contest, but you want them to preserve muscle strength. You will see a lot of COPD patients in the emergency rooms. When they come in an exacerbation, you see that their truncal musculature, their upper limb musculature is very wasted, right? So we discussed why pulmonary rehabilitation in the form of exercise and nutrition is important. Lung transplantation. Now, who are these patients who will benefit from lung transplantation? Those patients with stage 4 COPD, very severe COPD. So, an FEV1 of less than 30%, 30% or less are candidates, and those patients who are unable to carry out what's ADL, activities of daily living. So they are unable to look after themselves, they are so breathless that they are unable to bathe without assistance, they are unable to dress without assistance, they cannot leave the house, right? They are so breathless. So activities of daily living are interfered with, are impacted despite maximal medical therapy. I said that how do you stratify these patients, COPD patients, by counting their exacerbations and hospitalizations. The number 2, right? And the number 1. So any hospitalization, even a single hospitalization, means high risk, and exacerbations 2 or more. If those are not satisfied, the patient is low risk. So that means 0 to 1 exacerbations per year, no hospitalization, low risk, and 2 or more exacerbations and any hospitalization for COPD, high risk. Now let's go back to that daunting looking graphic, right? So it's divided into 2. So the low risk patients are group A, again less than 2 exacerbations, no hospitalization, and group B, right? The high risk patients, either 2 exacerbations or more, or even a single hospitalization, are group C and group D. How are they further subdivided? According to how much limitation they have. What is the biggest limiting symptom that a COPD patient will have? Dyspnea, breathlessness, right? And when they are not slowed down due to dyspnea, MMRC grading, if you want to remember that, an MMRC grading of 0 or 1. 0 means breathless only on strenuous activity. 1 means when hurrying on the level or walking on a slight incline. That if they are breathless in those situations, they are categorized. So to help you simplify that, I have said when they are not slowed down due to their dyspnea, within those 2 categories, they have less severe disease. So group A and group C are not slowed down due to dyspnea. When they are slowed down due to dyspnea, they are groups B and groups D respectively in the low risk and high risk categories. And treatment is also very simple. It's stepwise therapy, right? So to sum that up, group A patients are those patients who are low risk and low dyspnea. These patients will be treated with short-acting muscarinic antagonist and short-acting beta agonist inhaled therapy as required, right? While we have defined COPD as a disease with persistent symptoms, when they begin to have symptoms, they will also have, this category of patients will also need bronchodilator therapy only intermittently, right? Group B patients, which means patients with low risk but high dyspnea, these patients will require regular therapy with long-acting muscarinic antagonist and long-acting beta agonist, a combination of the 2 medications, right? When we go to group C and group D, now we are dealing with patients who have a high risk of exacerbations. They've already had frequent exacerbations. The biggest risk factor for a future exacerbation is a history of a past exacerbation. So we want to prevent that. So we need to add therapy. We need to take care of symptomatology. We need to add therapy that will reduce exacerbation, right? So we give them long-acting muscarinic antagonist and inhaled corticosteroid therapy as combination, right? And when they have dyspnea despite such therapy, or they are the high risk patients, category D is high risk patients with high dyspnea. Now these patients will need a combination of long-acting muscarinic antagonist, long-acting beta agonist and inhaled corticosteroid. You also add roflumilast. We've discussed this. If FEV1 is less than 50%, so stages 3 and 4 COPD in ex-smokers, 6 months of daily macrolide therapy will reduce further exacerbation. So the stress in high-risk patients, those with frequent exacerbations or a hospitalization due to COPD in the past, the stress is on preventing further exacerbations. The stress in low-risk patients, those who have never been hospitalized in the last 1 year, those whose exacerbations are limited to 1 or none in the last 1 year. We are more focused on providing symptom relief, right? Okay, let's keep moving. An exacerbation of COPD will be marked by worsening of dyspnea, so they'll become more breathless, their respiratory rate will be higher, they'll be tachypneic, and they'll be visibly distressed due to their breathlessness. The cough will increase, the volume and purulence of secretions will increase. There will be more wheezing than usual, right? I told you the strongest predictor of a future exacerbation is an exacerbation in the past, which explains why group C and D patients are considered high risk COPD patients. What are other risk factors for exacerbations? We've already discussed that frequent exacerbations are more common with an FEV1 of less than 50%. Besides this, on the CT, so this is another benefit of doing a CT in COPD patients. When the pulmonary artery to aorta diameter ratio is more than 1, that is an indicator of risk for future exacerbation. It is also incidentally a better marker of pulmonary hypertension than doing a 2D echo, right? Besides this, if they suffer from gastroesophageal reflux disease. Now, why is gastroesophageal reflux disease a risk factor for exacerbation? Is because when they have reflux, there is a very high chance of micro aspiration into the lung. How do pathogenic organisms reach the lung? Because the lung, while the lung does have, the healthy lung also does have, it's not sterile, there are few microbes, but pathogenic organisms reach the lung by different mechanisms. It can be a hematogenous seeding, right? It can be a contiguous infection from, let us say, the pericardium or the pleural space. But the most common mechanism for a pathogenic organism reaching the lung is by microaspiration. All of us microaspirate when we sleep, but we clear those organisms on those whatever we aspirate, that content that we aspirate, those microliters of content, by the normal ciliary activity of the upper airway. Since that is compromised in the COPD patient, GARD is a risk factor for exacerbation in COPD. This is further compounded if they are also on proton pump inhibitor therapy, because then the sterilizing effect that gastric acid has on the upper GIT will be lost, and they will be more likely to have a high volume of pathogenic organisms in their upper gastrointestinal tract, right? What does a patient with COPD exacerbation look like when you see them in the ER, or if they come to the OPD? So they'll be in distress, right? And distress is a loose term. What does it look like? They'll be tachypneic. Their respiratory rate would be more than 30. They are used to, so while normal respiratory rate is 12 to 20, right? These patients with COPD are used to a respiratory rate of 24 to 26. A respiratory rate of more than 30 in this patient means that this patient is experiencing respiratory distress. You will see that the accessory muscles are being used. You should also look for thoraco-abdominal paradox. What is a thoraco-abdominal paradox? Normally, when I breathe in and when I breathe out, the abdominal wall and the chest wall move together. Both move out with inspiration and move back in with expiration. This is a paradox. If with inspiration the abdominal wall moves in and with expiration moves out, that is called thoraco-abdominal paradox. It is objective evidence of respiratory muscle fatigue. If you should see this, that means you have to ventilate your patient. There is no other treatment for this complication, right? You also, while you're worried about distress and tachypnea and unacceptably high, so we are looking for unacceptably high work of breathing and its consequences. Distress, tachypnea, accessory muscle use, thoraco-abdominal paradox all tell you that the work of breathing is unacceptably high. If you don't see that patient in that phase of illness, you happen to see this patient 30 minutes later, what are you going to witness? You're going to witness insufficient ventilatory effort. So, despite the poor blood gases, despite the hypoxemia, the hypercapnia, the respiratory acidosis, this patient, when you see them late in this natural history of the exacerbation, your patient might not be tachypneic. Indeed, they might have bradypnea, they might be gasping. So, gasp is an insufficient ventilatory effort. When you see, as opposed to, this is a normal breath, right? My breath is not shallow. When breathing is shallow, I'm only ventilating most of my upper airway. The breath does not reach, the fresh air does not reach the peripheral lung. That is insufficient ventilatory effort, and again that is an indication for mechanical ventilation. So, those could be the various initial impressions of the patient you get off with a COPD exacerbation. There could be a lot of other things, right? They could be confused. They could be, and anything on that scale, confused, drowsy, comatose, right? And why? There are multiple reasons for that. The commonest would be hypoxemia, right? Besides that, it would be complicated by sepsis. Hypercapnia also causes alteration of sensorium. Another phenomenon that can alter the sensorium in this situation is hypotension, and you can measure that objectively when you see their blood pressure, right? And hypotension, the commonest cause there would be a septic shock, right? Another reason for hypotension in a COPD patient with exacerbation. So, one COPD exacerbation with shock or hypotension, one reason is a septic shock with an LRTI. Can you think of any other reason? Again, very even more immediately life-threatening is a tension pneumothorax, right? That's another cause, and we discussed that when we've discussed pneumothorax, right? What would be the typical ABG picture? They'll have severe hypoxemia and they'll have respiratory acidosis with hypercapnia. So, a pH of less than 7.30, see, while pH of 7.35 to 7.45 is normal pH, patients who have a chronic hypercapnia, they compensate. How do they compensate? The kidney excretes more acid. On the ABG, that excretion of excessive acid is visible. You can make that out. The indicator of that is that bicarbonate is elevated, right? So, this compensation of the kidney, this renal compensation, brings the pH back towards normal, right? So, you can expect a pH of between 7.30 to 7.35 in stable COPD, right? When the pH is less than 7.30 with a PCO2 of more than 50, that means this is a recent phenomenon. This is acutely developing respiratory acidosis. Okay. So, on the ABG, you will see severe hypoxemia and you will see hypercapnia with acute respiratory acidosis, right? Now, we have already discussed this, that infections can cause exacerbation, pneumothoraces can cause exacerbations, a pulmonary embolism can cause exacerbation. Why is this important here? Is because when a patient with COPD comes with an exacerbation, these are all the things that you must consider. If you miss a pulmonary embolism, you might think that the hypotension is because of sepsis, or you might think the hypotension is because of what I just said, tension pneumothorax. There's a third cause of hypotension with an acute exacerbation, and that is a massive pulmonary embolism, right? You might even not get to see any deep vein thrombosis in these patients. Then where did the embolus come from, right? Because they have cor pulmonale right ventricular dilatation. Their right heart blood flow is so sluggish that they can develop right ventricular thrombosis, and from that thrombus a part embolizes to the pulmonary artery, right? So, that is another thing that you must consider for COPD patients in an acute exacerbation. We discussed how reverse Bernheim effect can cause biventricular failure, and that is also another cause of acute exacerbation in COPD, right? How do you manage these patients? You give them initially short acting beta agonist and short acting muscarinic antagonist, initially nebulized, and you give them antibiotic. We discussed how you choose your antibiotic therapy empirically. Non-invasive ventilation, non-invasive positive pressure ventilation by a facial mask, tight face fitting mask improves clinical outcomes. Now, when do you give that? You give that if pH is less than 7.35 with a PCO2 of more than 50. Typically, these patients, they will do well on NIV if their pH is between 7.25 to 7.35. If the pH is less than 7.25, they will not do well with non-invasive ventilation. They will most likely require intubation and intermittent positive pressure ventilation. Okay. Besides this, any other indications for using non-invasive ventilatory support is, again, if you see that the patient is having an unacceptably high work of breathing. So, if the respiratory rate continues to be more than 30 despite medical management, you're giving supplementary oxygen, you've started antibiotic, you've started bronchodilator, you've given, remember that parenteral steroid or oral corticosteroid is used for an acute exacerbation, right, especially when they are hospitalized. So, when all that has been done, the patient still has a respiratory rate of more than 30. The higher the respiratory rate, the greater the chance that this patient will go into respiratory muscle fatigue. And then if you allow that fatigue to set in, at that time non-invasive ventilation will be of no help. Then you have to intubate your patient. So, it must be preempted. You must be able to foretell that this is unacceptably high. I need to support this patient's ventilatory effort so that it does not go into fatigue and does not require intubation, right? Besides this, then there is the obvious indication that if the partial pressure of oxygen remains less than 60 despite an FiO2 of 0.5 or more. So, with 50% oxygen or more, if the PO2 still remains less than 60, that is also an indication for non-invasive ventilation, right? Their saturation, the target saturation is, we are not targeting a normal saturation, we are targeting a saturation of between 90 to 94%. Even 89% is during an exacerbation, provided their work of breathing is not high. So if someone comes with an exacerbation, we give them initial therapy, we're giving this patient 40% oxygen with a Venturi mask, the patient's respiratory rate is 26, saturation is 89%, is hemodynamically stable, alert, I would not want to give any kind of ventilatory support. The pH is also let's say 7.32, right? I would not want to give this patient ventilatory support. But if any of those indications are there, especially if they are, and they will occur together, right? So if those indications are there, that is indication for providing non-invasive ventilation, right? Now see that as we have discussed indications, then there must be some contraindications also, and these contraindications imply that the patient does require ventilatory support, but non-invasive ventilation is not an option, and you must intubate the patient and provide intermittent positive pressure ventilation, right? Invasive ventilation. So hypotension is an absolute contraindication. When the patient's sensorium is questionable, when the patient's sensorium is altered, when the secretions are very voluminous or very thick, because then the patient cannot clear out those secretions on their cough reflex is compromised because of their poor muscle mass, because of the infection, right? So copious secretions are a relative contraindication to non-invasive ventilatory support. Besides that, if their BMI is more than 40, the non-invasive ventilator cannot deliver air at high pressure to the respiratory system of such a patient, because chest wall is very heavy. In that situation, you will need to put in a tube for better control, right? If there is a craniofacial abnormality, retrognathia, that does not allow the mask to be fitted well on the patient's face. Okay. So we already discussed, if the pH is less than 7.25, you will need to put in an endotracheal tube, right? And that NIV is best suited when the pH is between 7.25 to 7.35. I rest my case. All the best.